as usual, technical difficulties, always it seems. I'm very happy to speak to you today. And I've given this lecture before many times, and I decided to update it. So the original lecture, I've looked at it, it's actually quite good. And for all the basics, and that all stays the same. Positron is still a positron. But I wanted to add new developments since the time of that. If you want to hear that introductory lecture to go over and learn what a positron is, for example, you can, it's a recorded lecture on YouTube. If you just type my name, Robert Innis, and PET, you'll be able to hear it. It's actually part of the clinical pharmacology course. Today I'm going to talk to you about exciting developments for PET in oncology, neurology, and even psychiatry. I'm a psychiatrist. What I will talk about at the beginning is that there are specific proteins, targets, but all of the targets in PET are proteins that have FDA-approved PET radioligands for diagnosis. They include, for example, prostate-specific membrane antigen for prostate cancer, PSMA, and also beta amyloid and tau protein, two proteins that accumulate detrimentally in Alzheimer's disease. The targets are linked to therapy, and I'll show that to you. The radiotherapy in the case of prostate cancer is done by substituting a different radioactive atom. So one atom, which is not dangerous, is used for the PET imaging, and then they put a different nuclide in there that deposits high energy and kills the tissue that has PSMA. So this is a combination of a therapeutic agent with one radionuclide and a diagnostic agent with another one. And also in the case then of continuing neurology and the beta amyloid, you can select dementia patients for whom they would be likely to benefit from anti-amyloid therapies. And 3 have now been approved. So these are really spectacular developments, very exciting. And my question that I'm going to pose for you all here is, are oncology and neurology models for PET in psychiatry? Okay, prostate cancer, PSMA. These slides were provided by Esther Mina and Peter Choiki from NCI here. And prostate-specific membrane antigen, PSMA, is a transmembrane carboxypeptidase that is highly expressed on prostate cancer cells. Expression of PSMA has been identified in more than 95% of PCA tumors. And there's a direct correlation between the PSMA expression levels and tumor aggressiveness, disease recurrence, and time to progression. So this is very useful for prostate cancer. This looks at the distribution of radioactivity following injecting an F18 labeled radioligand. And this is for like a normal subject. And you can see that it distributes to the kidneys, the salivary glands, etc. But if you look in someone with prostate cancer, you can see all of the numerous metastases along there. And right close to the bone, vertebra. This is the agent, by the way. Francis Collins, the former director of NIH, announced within the past year in an editorial in the Washington Post that he had prostate cancer. And he was praising the research developments at NIH that has helped him, and he talked about this PSMA scan that he had. He has, I think, a pretty aggressive form, I remember that correctly. But it was this agent. Okay, so there's the opportunity not only of diagnosing the disease and knowing where it has recurred, but also to combine it with a therapeutic agent. The diagnostic agent is the PET radioligand to localize the tumor, and the therapeutic it's a radionuclide that deposits cytotoxic, cell-damaging radiation. So in the case of PSMA, they can use F18 labeled PSMA for which is a positron emitter, and annihilates with an electron, and it generates 2 high-energy gamma rays, most of which pass through the body and are detected by the camera. In contrast, you can label it with lutetium-177, which is a high-energy beta emitter, and it will destroy the tumor, nearby tumor, after it binds to this receptor. Both the diagnostic agent and the therapeutic agent are approved. I've been seeing advertisements recently for the therapeutic agent. Look for it when they talk about radiation treatment for prostate cancer. So this is just fantastic. I can tell you, we don't have anything like this in psychiatry, nothing. And here's a dramatic example of multiple metastases identified, and then after 4 cycles of the lutetium-177, just wiped it out from what could be seen. So, and the PSA was 27, up at this top. I don't know how to move that. Oh, maybe I can do it. So 27, it went down to 0.02. So it can have dramatic effects. Let me give you another example from oncology, and that was work from Dr. Jha and Pachak. And I believe Pachak recently departed NIH. But they both gave me these slides, and it's PET imaging of paragangliomas. Paragangliomas are rare neuroendocrine tumors arising from chromatin cells, and they're characterized by catecholamine and/or their metabolites. The locations of the primaries can be any place in the body where chromatin cells are present, from the base of the skull to the bladder. And the most common one is probably the pheochromocytoma, or a pheo, where the primary tumor arises from the adrenal medulla. These tumors have somatostatin receptors, SSTR. And this is shown here. So the somatostatin receptor is the SSTR here. It's bind in a locking T fashion by Tate, some compound that will go just bind only to the SSTR, connected via DOTA to either lutetium-177 to be therapeutic or to gallium-68 to be diagnostic. And here's examples of this. You can also measure it with F-DOPA. So they're showing here, you can do it with F-DOPA, you can do it with FDG, but in general, the gallium-68 dotatate is heart radiosensitivity, and it can be seen much more often, as characterized by these color scales down here. And you can identify even subgroups of these based upon the imaging. So this one is the Pachak-Zine syndrome, and we don't have any possibility of doing this now in psychiatry. Okay, so what about neurology? Neurology has had major advances with the development of radioligands for amyloid and tau, 2 proteins, misfolded proteins that accumulate in the brains of Alzheimer's disease. And this is the first report, the imaging of brain amyloid and Alzheimer's disease, with a compound from Pittsburgh. It was published in 2004, and you can see this is a normal control, a little bit less normal, and a mild cognitive impairment, and then the full-blown AD. There's a progression. You get a full amyloid load just in mild cognitive impairment. And these slides were from Julie Price, who was involved with these studies. She's now at Harvard and MGB. So this was discovered, first reported in 2004, and it was approved in 2012. So this gives you, therapeutic compounds, you're talking about 20 years to approval. But for a diagnostic, which is given in subpharmacological doses, which have no pharmacological toxicity from it whatsoever, it can be very, very quickly. So if we can develop things appropriate in psychiatry, they could be approved in a relatively short period of time. And how can this be, how is it linked? So in this article from 2023, reports the use of lecanemab. This is an antibody to amyloid, and it'll remove the amyloid from the brain. And if you do the amyloid imaging, it's absolutely dramatic how much amyloid is removed. There are, however, significant side effects of bleeding and edema, swelling in the brain, which require an annual MRI to see if you're having these side effects. It's not very effective, but it did have clinically significant effects, and this is, I think, the first demonstration. The way it's linked to PET is that in order to get the treatment with an amyloid antibody, which has severe side effects, you have to show that you have amyloid. And one way of doing that is with an amyloid PET scan. So major developments in neurology, PET radioligands approved for tau, and they will be used in the evaluation of anti-tau therapies. PET radioligands are being tested now for alpha-synuclein. Alpha-synuclein is a protein that builds up in Parkinson's disease as a potential diagnostic in PD. And PET radioligands are also being developed for this LRRK2, and there are abnormalities in this gene that are linked to Parkinson's disease. So I think you would agree with me. These developments are just absolutely stupendously exciting in oncology and in neurology. But is PET in oncology and neurology leading a path for psychiatry? And I'm going to have to give a modulated answer, a yes and a no. Yes, psychiatry certainly wants their success in diagnosis and treatment, but no, in that we do not have any proteins that are necessary and sufficient for the diagnosis. If to have the diagnosis of Alzheimer's disease, you must have amyloid, period. In years past, the only way you could have the definitive diagnosis of Alzheimer's disease is at postmortem. They look directly in the brain tissue. But with this PET imaging, you can see. You may have someone you suspect of having Alzheimer's disease, but if they don't have amyloid, they don't have Alzheimer's disease. They have some other sort of dementia. So psychiatry is at an earlier stage, and we need to, at this point, discover what the relevant targets are, recognizing that the distribution will overlap with the controls. It won't be like Alzheimer's are amyloid positive and controls are amyloid negative, because there's big overlap, let's say in depression, for example, in the normal population. Multiple types of depression, different course of different responses to treatment, overlapping with normal symptoms. So recognizing that the distribution is going to be partially overlapping with controls. So what I've done in my career is say, okay, well, what targets should we look at? And what I've looked for are ones that are likely to be linked to treatments. Patient stratification. Just like if you want to stratify patients with dementia for those going into amyloid, let's do an amyloid scan. Well, let's say in depression, a subset of depression is caused by, let's say, inflammation. Let's identify that subset of patients with depression that have neuroinflammation and treat them with an anti-inflammatory drug. So this patient stratification is now called precision medicine, by the way, but it is the same thing that I learned in medical school. Okay, so I'm going to talk to you about sort of the strategies taken for looking for this patient stratification with regard to imaging of cyclic AMP activity. Cyclic AMP is a ubiquitous second messenger in the body. Phosphodiesterase 4 is the primary enzyme in the brain to metabolize cyclic AMP. PDE4B and 4D are the most abundant. Inhibition of PDE4B has antidepressant-like effects in rats. Inhibition of P4D is procognitive in rats, so improved dementias. We've done studies with the PET radioligand C11 labeled rolugram, and it binds to all 4 subtypes. There's A, B, C, and D. And I'll show you how we can use that as an indirect biomarker of cyclic AMP activity. And we have found with this rolugram that it's decreased in depression and it's increased after 2 months treatment with SSRI. And this is consistent with long-standing, decades-long-standing idea that some depression is associated with decreased cyclic AMP activity, and that weeks-long treatment with an antidepressant increases the cyclic AMP activity. So that's the connection to treatment. Another important one with regard to connecting to treatment is that PDE4B is elevated in peripheral inflammatory cells, and its inhibition is anti-inflammatory. There are 2 currently approved drugs, apremilast and roflumilast. Apremilast is advertised on television a whole bunch. So it binds to all 4 subtypes, and it's used for psoriasis and psoriatic arthritis. Oh, Tesla is the brand name. Although it binds to all four, its activity as an anti-inflammatory is by blocking PDE4B. So this is the connection, certainly with the PDE4B also. Thinking about the brain too, we'll get back to that. So here's an example of the cyclic AMP cascade of PET imaging. And it shows that various neurotransmitters can act via receptors, beta-adrenergic receptors, and a G protein, stimulatory protein, to adenylate cyclase to produce cyclic AMP. So it increases cyclic AMP. Cyclic AMP activates PKA, protein kinase A, which phosphorylates CREB and has multiple actions. And these help to mediate the neuronal plasticity, the cell survival, and probably also the antidepressant effects of several antidepressants. This signal is terminated by being metabolized by phosphodiesterase 4 in the brain. And what we do is we have made a C11 labeled ligand, roligram, which binds to all four subtypes of PDE4 and imaged the density of this enzyme, phosphodiesterase 4. An important aspect of this is that there's a negative feedback, so that, yes, cyclic AMP activates PKA. PKA, in addition to phosphorylating CREB, it also phosphorylates PDE4, increasing the metabolism. So it's a negative feedback system. If there's too much cyclic AMP, it will act via PKA to activate the enzyme that metabolizes it. It's sort of like a thermostat and room temperature. It gets too warm, the thermostat will shut down and stop the production of heat, or in this case, stimulate the destruction of cyclic AMP. Okay. Well, in order to see whether this occurs, to see whether this is known to occur in vivo, whether we can measure it with PET, we injected into one side of the brain either a PKA activator or a PKA inhibitor. And as you can see that we injected in one side of the rat brain in the striatum, there was significantly increased uptake on the injected side compared to the control one. So this is consistent with PKA phosphorylating PDE4 and increasing its affinity tenfold, and also increases its activity. We say, oh, maybe this is just a blood flow effect. Well, no, it ain't, because we also have the inactive enantiomer. So this effect is enantiomerically specific. And the only thing that's enantiomerically specific about roligram is its inhibition of PDE4. So we did this with an activator. We also did this with an inhibitor. So we have evidence in animals that this PKA feedback system, when phosphorylating and activating the enzyme, has the appropriate effect on, has the expected effect on cyclic AMP and radioligand binding. Well, does this occur in humans? We were able to make use of a rare mosaic genetic disorder called McCune-Albright syndrome, in which some organs or some portions of organs have this genetic defect in GS-alpha, that stimulatory G protein I mentioned. And the result of it is that in the affected tissues, there's increased cyclic AMP activity. I mean, this is known. So we said, in that case, there should be increased uptake of roligram. And sure enough, there was. One of the most prominent abnormalities in these patients is like swollen bones, sort of, or fibrous dysplasia is the correct term. And you can see that in the areas of fibrous dysplasia, which you can see here, there's increased binding of roligram, consistent with the notion that cyclic AMP is activating PKA and showing in the human that this feedback loop exists, and you can see increased cyclic AMP activity by increased roligram binding. This is a typical what's called a bone scan, F18 label. This bone is being, bone in general, but this bone in particular, is being made and broken down, made and broken down. So there's a lot of remodeling of the bone. And sodium fluoride is taken up in bone that is being remodeled. So it's in some of the same areas that are undergoing bone remodeling, as seen with the sodium fluoride, fluoride in the toothpaste going to the bone in the teeth. Okay, so this occurs in animals, this occurs in humans. So our study then in PDE4 looked at unmedicated patients with MDD and had a global 18% decrease of milligram binding compared to healthy subjects. So it confirmed the theory that low cyclic AMP predisposes to depression. This is one that's gone around before I was in medical school. And then we scanned the subjects after 2 months treatment. The effects of an antidepressant therapeutically and their effects on cyclic AMP require several weeks of treatment. And for this SSRI, selective serotonin reuptake inhibitor, like Prozac, treatment for 2 months increased the milligram binding by 12% in the 23 patients who stuck around for the second scan. So this confirmed numerous animal studies showing that chronic antidepressant treatment upregulates the cyclic AMP cascade. PDE4 is a therapeutic target, that's for sure. Animal studies suggest that subtype selective inhibitors may help. Inhibiting PDE4B has antidepressant-like properties in animals. So how about in humans? Inhibiting 4D has pro-cognitive effects in animals and in one human study. However, the studies that were done, like with raclopride, for example, or non-selective inhibitors, apremilast, is that you get nausea and vomiting. So there's dose-limiting toxicity, and that's thought to be mediated by inhibiting PDE4D. So we made radioligands selective for 4B and for 4D, and we're looking at them in human subjects. Here's a monkey study, and looks at the uptake in the monkey brain with highest densities in the thalamus, but it's in all areas. This radioligand is injected in tracer doses. It occupies less than 1% of the enzyme. It has no pharmacological effects. And then if you block it, you can see it's just a dramatic blockade. There's a huge specific to background ratio. And this, you can look, if you look in the baseline scan and after the blocked, the concentration, do that numerically, you can see that. We've extended this to human subjects now. Here, again, there's widespread distribution. The highest is in the thalamus, and we've done a full quantitation of this. Let me show you one way in which we're going to try to link this to therapy. So this has to do with chronic alcohol use disorder. So this is a paper that is accepted today. Looking at PET imaging in rat brain shows opposite effects of acute and chronic alcohol exposure on PDE4B, an indirect biomarker of cyclic AMP activity. I might also mention here that in the largest genome-wide association study published to date, and this one was about a year ago, in which they had more than 1 million subjects, the gene with the highest correlation with alcohol use disorder and substance use disorder was PDE4B. Okay, the key findings here is that acute ethanol increased PDE4 radioligand binding for about 4 hours, but it came back after 6 hours. And there have been studies going back to the 70s which show that acute ethanol, alcohol, will increase cyclic AMP activity in the brain. So this is consistent, showing that we can measure it with PET. And that chronic administration of ethanol decreased the PDE4 binding at 5 hours after abstinence, beginning abstinence, and it normalized in 3 to 14 days. So here's an example of the effect of acute ethanol. And you can see that this is sort of the PET measurement of how much is in the brain. It increases substantially, peaks at about 4 hours, and comes back by 6 to 24 hours. So you can see it's got the high of alcohol and it came up, finished up. Here is the time activity curves, looking at it numerically, and a saline animal and an animal injected with ethanol. Okay. What happens if you give the ethanol chronically for weeks? So you have the dependent animals and the non-dependent. The non-dependent are the controls. And you can see that there's the dependent animals down here have less binding, consistent with low cyclic AMP activity. Okay, so the summary of this is that acute administration increased the binding, acute ethanol presumably increases cyclic AMP, pKa phosphorylation, and radioligand affinity. Chronic administration decreased PDE4 binding, and that would be associated with decreased phosphorylation and decreased affinity of the PDE4 for alcohol. So the treatment implication of this, if during alcohol withdrawal you have low cyclic AMP, well, you might be able to treat someone during alcohol withdrawal with a PDE4 inhibitor to block the metabolism and increase the cyclic AMP. And in fact, those studies have been done, recently published, in which they used apremilast, which inhibits all 4 subtypes, and it decreased symptoms and increased length of sobriety after withdrawal from alcohol. So this occurs in animals. Does it occur in humans? Our protocol is under review, but we're going to be doing the same thing, basically. In social drinkers, normal people, we'll give the ethanol, and we expect to see an increase. It'll be given intravenously. And also, we'll be looking at chronic patients with alcohol use disorder that go, I think, on the first floor here, have a 28-day withdrawal or detox program, and we'll image them during the first week and during the 4th week of their in-hospitalization stay. And our prediction is that it is decreased in acute withdrawal. One could think that this could be linked then to selecting those patients who were most benefited by a PDE4 inhibitor. And furthermore, if we could use a PDE4B selective inhibitor, we would avoid the nausea vomiting associated with PDE4D. Okay. And another important connection for PDE4B clinically is that this protein is markedly elevated in peripheral inflammation. By markedly, I mean 5 to 10 folds higher. And because of the increased protein, then the cyclic AMP is decreased. So in many peripheral inflammatory disorders, big increase in PDE4 and a big decrease in the cyclic AMP. The way it's treated is by a PDE4 inhibitor. I mentioned there are 2 non-selective PDE4 inhibitors that are approved to treat inflammation in either COPD or in psoriasis. So the elevated PDE4B protein in peripheral inflammatory cells metabolizes cyclic AMP. Pan-PDE4 inhibitors, all 4 subtypes, apremilast and roflumilast, are approved to treat inflammation in COPD and psoriasis. Its mechanism is via inhibiting 4B. And a selective, this was reported just 2 years ago, a selective PDE4B inhibitor, the first selective inhibitor reported to date, decreases inflammation and prevented progression in idiopathic pulmonary fibrosis. This is in the New England Journal of Medicine, and this is a rare disorder that is rapidly progressive and deadly. So, what are we going to do? Well, can we see inflammation in the periphery in animals? And we have actually begun this study, and the answer is yes. So we're imaging monkeys over, I think it's at building 32. It's the building I've never been in and never will be in. Not allowed, because of all the infectious agents there. We used the PDE4B, they were imaged with PET in that building, and sure enough, there's 2 to 4-fold increase of radioligand binding in the lesions of these monkeys that are exposed to TB. And we're also going to be looking at another peripheral disorder with the clinical director of NIAMS, spondyloarthritis. And that protocol is approved, and we're currently recruiting subjects. So PDE4B elevations can be a marker of inflammation in the periphery. How about in the brain? Recent results from Dr. Paul Parkon here shows that if you inject, I've mentioned something like this before, LPS, you can also inject beta amyloid. Beta amyloid causes inflammation, and you can see it here. and there is an increase in PDE4B binding. This shows an example of lipopolysaccharide is from polysaccharide from the wall of bacteria, which causes inflammation. And you can see it really a significant increase on this side of the brain. Okay, and here's more quantitative value. Okay, so now we have a marker of inflammation, and we're going to be looking at this and we are looking at PDE4 now currently in several disorders that have proposed inflammation, including Alzheimer's disease, depression, and long COVID with brain symptoms with AVI-NAV. Okay, well, that's the one type. We've also developed a radioligand for 4D. Mind you, inhibiting 4D is cognitive, sort of as maybe you would expect for a procognitive effect. There's higher uptake in the neocortex. It's blocked, and this was just reported this year. And we're now doing studies with 4D, or we just submitted an IND for this investigative new drug application to study that in human subjects, healthy subjects. We previously found that the PDE4 inhibitor rologram was decreased in MDD. We will now determine whether the decrease is selective for 4B or 4D. And this is the proposal of Paul Parkon, now an assistant clinical investigator. And this makes perfect sense. We see a decrease in rologram which binds to all four. Well, is that a selective decrease with B or a selective to D or for both of them? And mind you, inhibition of one of them or both of them may be antidepressant. I'm voting for the 4B. Okay, so what I've shown so far is that we have to start sort of from scratch, do the mechanism studies, looking at pathophysiology and psychiatry. We do not have, and we will not have, anything like beta amyloid or a definitive diagnosis in, let's say, depression, because depression is far more heterogeneous. So this is an example of how we can look at, in this case, two types of phosphodiesterase 4B and 4D, as measures either of inflammation and or an indirect measures of cyclic AMP activity. As an extra little bonus, I want to mention, because I have time, the work that we've done that's better known and more active, and that is on cyclooxygenases. Cyclooxygenases are like COX-1 and COX-2, which are inhibited by non-steroidal anti-inflammatory drugs. So aspirin, ibuprofen, Motrin inhibit, their definition is that they inhibit either COX-1 or COX-2. And in the periphery, the inflammatory one is COX-2. And inhibition of COX-2 is used as an anti-inflammatory treatment. But in the brain, it's flipped. So you're going to see that the red goes to the other side. Oh, so COX-2 is in the myeloid cells, bone marrow derived cells, and it's involved with inflammation. In contrast, COX-1 is involved in homeostasis, the proper amount of platelet aggregation, the proper amount of pH in the stomach. So inhibition of COX-1 will give you an acidic stomach and cause ulcers. That's where the ulcers come from aspirin. In the brain, this is flipped around, as I mentioned. COX-1 is the pro-inflammatory one. It's located in microglia primarily, not exclusively, leads to inflammation. And the COX-2 is located in neurons, and its function is unknown. Okay, so we developed radioligands. I'll just give you a few pictures of this, of radioligands selective for COX-1 and COX-2. So this from 2018 looks at the uptake, and you can see that there's very high uptake in the spleen, the kidney, the GI tract. Inhibiting the COX-1 in the GI tract is what causes the ulcers. There's also significant uptake in the brain. And then if you block it with pharmacological doses of PS13, you can see blockade in those areas. So a pharmacologically specific binding. We've done this in human subjects now. This was published, I guess, just last year. So this looks at the uptake, baseline and block, in which the human subjects were given ketoprofen. Ketoprofen is a highly selective and very potent inhibitor of COX-1. And you can see the blockade. The spleen is the easiest place to see it. But if you give celecoxib, it's a minimal effect. Celecoxib is more of a COX-2 inhibitor. In fact, this is so good that you can use it to measure the in vivo potency of the drugs. So in this case, we gave increasing doses of ketoprofen, or decreasing doses of ketoprofen, oral. And then we did a scan before and after various doses. This up here is 75 milligrams of ketoprofen, 75 milligrams. That's the smallest capsule, and yet that caused 100% blockade of COX-1 in spleen. Now, virtually 100%. In order to get down to this, we had to reformulate it into capsules down to 1 milligram to just show you how potent it is. And this 50% level here, which is associated with about 0.2 micromolar, that's what you get from 2 milligrams. So you can see that this is really extraordinarily potent. In contrast, you can go up to much higher concentrations with celecoxib. Celecoxib is primarily COX-2. It does have a little bit of COX-1 inhibition. You can calculate the in vivo IC50, and that's shown here. The COX-1 uptake was well quantified in the brain. So this looks at the subjects all have an arterial line in place, and we measure the parent radioligand in arterial plasma. This looks at the concentration of radioligand in arterial plasma at various times. And this is the uptake in the brain. The highest uptake is in the hippocampus, and then it was blocked, as expected, by the ketoprofen. This is what it looks like. It's blocked by ketoprofen. The highest uptake is in the hippocampus there, but it is throughout the brain, and it can be blocked by ketoprofen, not by celecoxib. And one thing that we can also do, because the uptake is very high in the cortex, we were interested in a method to try to measure the cortical binding in particular. And this shows how it's done in a free surfer, where this is basically a la free surfer, in which you identify the cortical ribbon and then sample from that specific ribbon area from the PET. And then you take the average from all subjects, and you can see that there's a very high density right around the central sulcus. This is the connection between the frontal and the parietal lobes. The line represents the base of the central sulcus. And this is the central sulcus. The red is parietal, the blue is frontal. If you blow it up, you can see then the banks of the central sulcus there. Okay, so this is under review. Okay, the take-home message with regard to COX-1, it's highest in the hippocampus, the occipital cortex, and the pericentral sulcus. It is blocked by ketoprofen. I didn't show this to you, but it has a high specific to background ratio. This is high for PET. It has good reliability on test-retest study. The intra-class correlation coefficient, which is measured reliability, is 84%. And the test-retest absolute variability is only 6%. So this is very good. So this is ready for use. We tend to be there, and I particularly tend to be very, very picky. I see no reason to try to develop a better COX-1 radioligand than this C11 labeled PS13. Now, I'm looking on one that's labeled with F18, which has a longer half-life. This one is fully approved, and it is in studies now in several disorders, including depression, dementia, and long-COVID with neurocognitive impairment. The COX-2, we have a radioligand in use in humans with COX-2. Really, we were served a curveball. So we wanted to try to develop the COX-2 radioligand. We did an injection of LPS, lipopolysaccharide, at this site here. And this is the staining. And this is 1 day after 1 day. huge amount of increase in the COX-2 staining, located significantly or primarily in neurons, by the way, going even to the other side of the brain. I won't give you the quantitation, but this is like, a tenfold increase. If you can see it visually, it's a big increase, and this is the control. The problem was that we did PET imaging, we couldn't measure any COX-2. Well, we more recently solved that mystery. This is a wild-type mouse, and these two are mice that have been transfected with the human gene for COX-2. So if you put in the human gene, then you can see it very, very clearly. And it can be blocked by celecoxib, the COX-2 selective compound. So the reason why we couldn't use the rats is because there's a species difference. And it's known actually for NSAIDs that you can have species differences between, let's say, humans and rodents. And this was one that caught us. Now we know what it is. So in order to look at this, we had to look in primates, non-human primates, which we did. If you look at baseline in a monkey, there's almost no uptake any place except in the ovary, and that's shown here. So this is the ovary, and that's one of the highest densities of COX-2 in the female body, of course. Okay, but in the brain is what we were after. So in order to do the brain, we did the LPS injection in monkeys, and we had to use monkeys because this does not work in rodents. And what we found was on day 1, after intracerebral injection here of LPS, there was a marked increase throughout the brain that could be blocked. So this is a rapidly upregulated biomarker of neuroinflammation. When we gave a second injection, it gave like even a bigger and more massive effect that could be blocked. It was regionally located because there was actually a lesion in the brain. Okay. If you look at normal monkeys, we can't see the COX-2, as I mentioned. We can't see it any place except in the female ovary. We cannot measure it. We see no displaceable binding in the monkey brain because there's just too low a density. So is this going to work in humans? So we went to humans that had rheumatoid arthritis. And where in the rheumatoid arthritis, it's known that in the affected joints, there's a marked elevation in COX-2. And we could see it in the joints, and we could block it at least partially by celecoxib. If we went to a higher dose, we'd be able to do it. So this gave us hope that just like the radioligand works in the monkey, it'll probably work in the human. So does it work, and can we measure it in the healthy human brain? And the answer is yes. This was a whole bunch of work, and it's under review. And what we found is that the COX-2 is primarily in the neocortex, as I showed you for the rat following LPS, and it can be blocked by celecoxib. Okay, so, and that can be fully quantified, and the documentation for that quantitation is that it's a very lengthy paper. Okay, so the future directions for COX is, COX can be a biomarker of increased microglia, and increased microglia is a marker of inflammation in the brain. It is being studied in several neuropsychiatric disorders. COX-2 is more of a dynamic biomarker. It can be rapidly upregulated in the periphery, and we have shown now in the brain. So we're looking at it for the effective anti-inflammatory treatments in both rheumatoid arthritis and ankylosing spondylitis. And we're also looking at it in the brain in disorders because it is an immediate early gene. There's like many genes that can be upregulated following damage or inflammation. So one is a more dynamic biomarker, and the other would be a marker of microgliosis. So in summary, we have developed PET radioligands for COX-1, COX-2, PDE4B, and PDE4D. And all of these targets could be linked to potential therapies. For example, anti-inflammatory therapies or therapies that would increase the concentration of cyclic AMP. COX-1 may be a marker of microgliosis. COX-2 may be a marker of active inflammation in the brain and in the periphery. And PDE4B can be both a marker for cyclic AMP signaling because of the phosphorylation site and of inflammation. it is known that inhibition is anti-inflammatory in the periphery. So we will be looking at this in the brain now. And inhibition of 4D will be starting healthy human subjects with 4D radioligand. Or it would be interesting to look at that not only in depression, but also in Alzheimer's disease. Okay, thanks very much. I'm happy to take questions.
So I was wondering, like, Cox imaging for the Alzheimer's disease, is there anything going on?
Could you say it again?
Like for Alzheimer's disease, PBR kind of imaging you mentioned about the tau and amyloid beta, but do we have COX-1 or COX-2 type of imaging on the patients of Alzheimer's disease showing neuroinflammatory changes?
So there is no neuroinflammation in the brain at the time of death in Alzheimer's disease, and it's hypothesized to play a role in the physiology or pathophysiology. And it may have a dual role of removing the amyloid from the brain a little bit, but also damaging the surrounding cells. So even if you have some treatments for the amyloid and the tau, there was a strong interest in looking at how much inflammation is in the brain and would an anti-inflammatory drug be helpful. With regard to TSPO, those were older studies that we've done, this translocator protein. And meta-analyses have come out, and it's very clear that TSPO is elevated in Alzheimer's disease and is correlated with disease severity. Some of the first studies, we did some of those first studies, and we have new and improved radioligands for it. So it raises the question that an anti-inflammatory therapy in conjunction with others may be useful. We're doing the studies with COX-1 and COX-2, and we do not have, it's still an ongoing study. But my hypothesis, or our hypothesis, is that COX-1 and or COX-2 may be elevated. And the way they could be used is if it is elevated, then it might identify those subgroup that could be treated with an anti-inflammatory treatment. Similar to how if once get an anti-amyloid treatment, which has minimal effect, by the way, you have to have a positive amyloid score. So it's using to these biomarkers of inflammation can be used to stratify a group of patients who have neuroinflammation and who may benefit from an anti-inflammatory treatment. The interest in anti-inflammatory treatment in Alzheimer's disease goes back to epidemiological studies in 15, 20,000 samples. And it showed that years-long treatment, maybe decades treatment, with NSAIDs, non-steroidal anti-inflammatory drugs, significantly reduced the incidence of Alzheimer's by 50%. So there's been a long-standing interest to try to use anti-inflammatory treatments in AD. It's more novel, I would say, to think about it with regard to major depressive disorder. And yet there's a very, very strong evidence, multiple lines of evidence, that at least in some people with depression, it is associated with and caused by inflammation in the brain and or in the periphery. Very strong evidence. So this TSPO, maybe a ligand that I mentioned, was studied, 7 out of 8 studies have shown elevated TSPO during a major depressive episode. So a colleague in Toronto did this TSPO imaging in patients during a major depressive episode. And then he treated them with celecoxib, the COX-2 inhibitor, and scanned them a month later. The celecoxib as an anti-inflammatory had effects. They were only modest effects, but they were almost exclusively, I think it was exclusively, in those who had elevated TSPO at baseline. So this may be used for patient stratification, precision medicine, to identify the subgroup of patients who have inflammation and would benefit from an anti-inflammatory treatment. Other questions?
I believe there's one online. Yeah.
Hello, Dr. Innis. Obada is here.
Hello.
Yeah. Thank you for the very insightful talk. And by the way, congratulations for the accepted paper. It's really great work what the molecular imaging branch is doing with regard to creating some application for PIT in psychiatry. I'm just curious to hear your thoughts on TSPO in psychiatric applications. Because to my understanding, PDE4 enzyme and also COX system are considered more of the novel targets, whereas TSPO has been, for instance, studied really heavily in neurodegenerative diseases like Alzheimer's and so on, with probably not so much of sort of say proven application yet as a marker of neuroinflammation. But just curious to hear your thoughts about it in psychiatry.
So for TSPO, translocator protein, which we're just discussing, it has been studied. It's the most studied PET biomarker of inflammation. It's been looked at in Alzheimer's disease. Meta-analysis, I think, very clearly showed that TSPO is elevated and correlated with disease severity. It's more located with tau than it is with amyloid. And it could be used to identify those subjects who would respond to an anti-inflammatory treatment. But here's the question, and I've spoken with pharma companies about it. They're very interested in getting an anti-inflammatory to treat the inflammation in Alzheimer's disease. One of the interests in PDE4B imaging is actually as an anti-inflammatory in the brain and in the periphery. So, okay, we're going to see whether an anti-inflammatory helps in Alzheimer's disease. Well, you give the anti-inflammatory. How long are you going to have to wait in order to see an effect of the anti-inflammatory treatment? Given that the disease progresses very slowly, and have you slowed the progression of the disease? You're probably going to have to follow patients for 1 to 2 years. Following patients for 1 to 2 years following an anti-inflammatory treatment is going to cost zillions of dollars. Wouldn't it be useful to know that if you gave an anti-inflammatory treatment, it was having an anti-inflammatory effect in the brain? That's where this dynamic biomarker, something like COX-2, may be useful. If you could find increased COX-2 in Alzheimer's, you give an anti-inflammatory and it decreased it. Say, okay, well, we know we're having an effect directly in the brain. I'll put in the box to see whether it's clinically effective for a 1 to 2 year follow-up. So I think that one of the ways that this can be used is not only a biomarker for diagnosis, biomarker for disease severity, it can be a biomarker to identify the subgroup that would respond, and it can also be used as a biomarker to see if your treatment really is having an anti-inflammatory effect itself. So does it demonstrate a pharmacological effect in the brain? I have a question for you or those online. Now this is a new talk for me. It's been 50 minutes. Was it understandable? Did I do too much? Did I do too little?
Yes, that's great.
Thumbs up. But if there are any thumbs down, let me know. I'll bring in the execution. If there's any down, those are the ones that I want to hear about. Because this is the first time I've given this lecture like this, anyway. And I'd like to improve it for the next time. Okay, well, thank you all very much for your attention.